Good morning, everybody. I'm going to have sort of a start here. Thank you all for coming and attending Orthopedic Grand Rounds. It's first day of February. I was going to talk about distal femur fractures, but we recently had a journal come out, and so I changed to discuss femoral neck fractures. So today I'd really like to talk about the primary, secondary, and tertiary outcomes from the recent Faith and Health Multicenter trials. So talking about femoral neck fractures today. Thank you for coming. All right, so we do have some objectives. First of all, just know that within the last 4 years, we've had publications of 2 large landmark trials. The first one was called FAITH, which is fixation using alternative implants for the treatment of hip fractures. This is basically DHS versus cannulated screws for femoral neck fractures. And the second one is HEALTH, hip fracture evaluation with alternatives of total hip arthroplasty versus hemiarthroplasty. These are all done in patients over the age of 50, and I'll go through the trials separately. And I wanted to speak about these because these are large, expensive studies. One had a budget of greater than $10 million. One was greater than $15 million. There's been a lot of effort, time, and money spent on these studies, and I thought it was worthwhile going through that. Also, just in November, the Journal of Orthopedic Trauma published a whole supplement journal with 12 additional studies looking at some of the secondary outcomes, which have some really interesting findings. So I thought I could easily fill up a whole hour talking about this, and that's where we are today. Thanks for coming. I have no disclosures other than I do like to be personally above average, and I could have subtitled this talk, How to Be Better Than Average at Hip Fractures. So Lauren Black, this slide's for you. We all know that the Dow Jones goes up long and slow, and if we were smart investors, we would just maybe invest in that over the 10-year average. But we all think we're smarter than the market, so we try a little gamesmanship along the way. Usually, given enough time, we all regress back to the average mean. Okay, so reminder, femoral neck fractures, they are important. 4.5 million people a year are disabled by hip fractures. It's in the top 10 cause of disability worldwide. And despite this and the importance looking at it worldwide, we've made minimal changes in outcomes over the past 30 years. The reoperation rate is still 10 to 30%. Death in a year is still 10 to 20%, and death in 10 years is still 70 to 80%. So a large group of researchers almost 15 years ago started looking at this and thinking about femoral neck fractures. Remember, we still have this long-term classification system by Garden that has been useful both to discuss osteonecrosis as well as fracture prognosis and treatment, and we still use that today. And so the first trial was envisioned in about 2002 or to 2004. This is an FAITH trial, international multicenter randomized trial. The inclusion criteria are patients age greater than 50 that were ambulatory. They could use a walker or cane. It was a low energy ground level fall. There were surgeon competency requirements for who could participate in the trial, and it was 24-month follow-up. And I tell you, if you go read this trial, there's a reason it got published in the Lancet. It is well done. All of the things that we criticize studies for statistical problems, they seem to have anticipated most of those from the outset. And one of the subsequent pieces of literature I found was quoted, "This trial will not only change current orthopedic practice, but will set a benchmark for the conduct of future orthopedic trials." So this is Mark Swinkowski and Mo Bandari, 2 really big thinkers in orthopedics trying to do the right kind of study. The primary outcome was reoperation in 24 months, secondary outcomes looking at mortality, healing, and complications, and a tertiary outcome looking at some patient-reported outcome scores. So here's sort of their inclusion diagram, and like I said, this was sliding hip screw versus cannulated screws. There were some requirements. The central screw in the sliding hip screw had to be greater than 8 millimeters, partly threaded, a 2 to 4 hole side plate, no derotation screw. Cannulated screws could be minimum of 2 screws, but as many as the surgeon felt were necessary, and they had to be 6.5 millimeters in diameter or larger. We have some things down at the bottom: surgery within 4 days of presentation, positioning or table. None of this group down here, that was up to the surgeon to decide. And we can argue, as we will see later, that some of those did become disagreements down the road. Although they were able to screen 7,300 patients, in the end they enrolled 11,000 with greater than 500 in each treatment arm. Again, this looks like a very well-designed study to my eye. It was international, multi-center. They ended up using 81 centers. The study was planned with 95% power for a relative risk reduction of 35%, comparing screws to sliding hip screw. There was an intention to treat analysis, and they planned for 6% crossover. So really, really well-designed trial. And hopefully we can get some good data from it. What they found, the average patient was 72 years old. 54% of them had a normal BMI. 19% were smoker. They did exclude dementia, and that's because they wanted to do the patient-reported outcome scores, and that may be a point of contention for all of us. They also, of the fractures, femoral neck fractures, 68% were non-displaced, so Garden 1 or 2. They did enroll 32% of the patients had displaced Garden 4 fractures, and I think for many of us, that is a fracture that we probably would not treat with internal fixation. But that was the study criteria at the time. I think the authors really felt that internal fixation was the gold standard. And 96% of the patients did have an acceptable reduction as adjudicated by central reviewers, not just the surgeon. So really a lot of good stuff in this trial. And here is the overall finding if you were to go read the abstract. Reoperations within 24 months did not differ by type of surgical fixation in those included in the primary analysis. 20% in the sliding hip screw group versus 22% in the cancellous screw group. They also found no significant difference between complications between these two groups. So the finding for this greater than $10 million trial is that maybe there is no difference. One of the follow-up studies did suggest that although a 20% revision rate is relatively acceptable for an internal fixation in geriatric femoral neck fracture cohort, it's easy to overlook that a study enrolled at, as I mentioned, 68% undisplaced fractures. And this is a statement that definitely gives me pause. I personally, in my practice, am unwilling to accept a 20% revision rate, even though the authors seem to think that was relatively acceptable. So let's go through the paper a little more closely. This is the primary finding, no difference between the groups. So first of all, yeah, no difference in any complication between the groups, cancellous screws versus sliding hip screws. There were no major differences in most of these surgical complications that we would look at as orthopedic surgeons. So the 2-year operation rate was the same for cannulated screws versus a sliding hip screw. However, only 66, about 2/3 of the patients actually had a healed fracture at the last visit. Somewhere around 25 to 30% of the patients had shortening greater than 5 millimeters if they did heal their fracture, and that may have some consequences to gait. The 2-year mortality was between 13 to 15% to these two groups. They did find a significant difference in the AVN rate, slightly higher with the sliding hip screw, and that matches some other studies suggesting that the larger bore 8 millimeter screw of the central screw may reduce the vascularity to the femoral head. So not a surprise, but they also noted that that group had no decline in their clinical outcome. They could not find any difference in any patient-reported outcome, the SF-12, WOMAC, and Euro Qual 5D. One of the really nice things they did in this study, I think we're all a little guilty of, is prior to starting the study, they did a secondary analysis, and they knew that these were the factors they were going to go back and look through multi-regression analysis to see if they had any impact. And I think most of us tend, when we design a research trial, to do this after the study is over. And they did a really nice job of labeling these prior to the study. And so they went back to look at these to see if any of these groups of factors had preference for sliding hip screw or cannulated screws. And here's their sort of forest type plot about that. To kind of run through it, you know, Most of the things slightly favored sliding hip screws, but it was a very, very small difference. That was mostly insignificant for all those things. Of what they did find was if you had a displaced femoral neck fracture, if you were a smoker, or if you had a base of the femoral neck fracture, those patients did better with a sliding hip screw than cannulated screws. All other fracture types, there was no difference between cannulated screws versus sliding hip screw. Very small differences. Okay, but that was undisplaced fractures, which is 68%. So what about the displaced fractures? I think most of us would treat those with some sort of arthroplasty. And so I think the clinical trials group recognized this and early on designed a second trial, HEALTH, which is basically total hip versus hemiarthroplasty. And so this was published just over a year ago in the New England Journal of Medicine. Overall, they were able to collect 1,495 patients, international multi-center trial. Again, they had over 80 centers, 10 countries, block randomized, over 10 years. The budget for this study was over $15 million. This is a very, very well-designed trial with almost equivalent inclusion criteria. So again, age greater than 50, patient with a low energy ground level fall, sustaining a femoral neck fracture. The patient had to be independently ambulatory, but again, could use a cane or walker. These were all displaced femoral neck fractures. So whereas the other trial could include non-displaced and displaced, this one was only displaced. There were surgeon expertise thresholds. The surgeon had to have done more than 25 arthroplasties total independently as a surgeon and more than 5 in the previous year. And once again, dementia patients were excluded. The primary outcome was reoperation within the first 24 months. Very interestingly, they set out to design this as a non-inferiority trial. So the initial question was stated as there's no difference between total versus hemiarthroplasty. And after looking at some of the initial enrollment of the FAITH trial, they quickly realized that that was not going to be very possible because it would have required 2,500 patients. So in 2006, before they started the study, they revised it to superiority design, stating that total hip would be better than hemiarthroplasty. This little statistical change dropped them down to needing 1,434 patients, designed with a 7% crossover and a 45% lower relative risk of reoperation in the total hip group. So again, very, very well-designed trial. Some of the best minds in orthopedics put this all together. Jason asks a very good question. Did they ask if the surgeon was joint strained? You will get an answer to that question by the end of the talk. Great. They did not ask it in the initial trial, but we do have an answer now. So overall, as they sort of collect this, there's no difference in the age of the patient, 79 versus 78. Most of the patients live at home, 95%, and some use a cane, around 25%. So I do think this population probably looks a little like our hip fracture population, so I feel like it was generalizable to me, but perhaps a little bit healthier knowing that dementia patients were excluded. And here is the primary outcome. Among independently ambulating patients with displaced femoral neck fractures, the incidence of secondary procedures did not differ between patients getting a total hip versus a hemi, so about an 8% reoperation for each group. No difference. Again, both regress to the mean. Okay, well, what about some of the secondary things? Okay, I said there was no difference in the primary endpoint, about 8% unplanned procedures. There was no difference in the death rate, about 13 to 14%. There was a slight difference in the dislocation rate. The total hip group had a 4.7% dislocation rate, and the hemi group had about a 2.4% dislocation rate. They collected data on the implant's approach, head size, and surgeon volume, but they did not specify any of that. And we'll get to that later as we get through the talk, that some of those things do matter a little bit. But they did note that the data seemed to fit other large trials, so they felt pretty good about it, that total hip had a slightly higher dislocation rate than a hemiarthroplasty. And I think that's something we would all naturally accept as part of diving in to do a total hip arthroplasty, but small difference. They did note that over 2 years, 40% of the patients had an serious adverse event. And these are major events. So I think we all know these are sick patients. That number was a little higher than I thought in my head, and probably something I should be telling families as I consent them for treatment to a hip fracture. However, only 8% of the adverse events were related to the hip. Mostly those were cardiac, renal, and neurologic events, and a 14% 2-year death rate. Okay. The adverse events at 2 years were slightly higher in the total hip versus the hemi group, and that was statistically significant. It was not one specific type of complication, so not cardiac, not neurologic, rather a small bump in multiple types of complications in multiple different physiologic arms, that total hip had a slightly higher 2-year complication rate than hemiarthroplasty. Okay. I noted that overall there was no risk of repeat surgery within the first 2 years after surgery. But if you go ahead and cone down, you can kind of see like, hey, wait, is what's going on up there? And here's the final data sort of blown up. So although the change is very small, the reoperation rate is a little bit higher in the total hip arthroplasty, i.e. the survivability of a total hip arthroplasty is less in the first 1.5 years, but there is a crossover point, and beyond 1.5 years, the total hip group has a slightly higher survivalship than the hemiarthroplasty group. So that's one of the critiques, and that was published in Journal, several critiques about what happens long term. We all do think that a total hip may have a little bit better longevity long term. And this study does not answer that question. However, we did have one recent trial that was published in the past year, looking at a randomized trial. This was greater than 100 patients in each arm, looking at Harris hip score outcomes in a randomized trial of total hip versus hemiarthroplasty at 12 years. First of all, only 20% of the patients were still alive at 12 years, so we're not really sure about the generalizability of this data. What they found is if they asked patients who were satisfied, the hemi group was slightly more satisfied than the total hip arthroplasty group, but there was no difference in the Harris hip score, and overall the group felt that the functional decline of this aging population outweighed any long-term benefit of a total hip arthroplasty. So coming back to this slide, certainly the health group can ask about the long-term options. I do think this is a challenging group to follow long-term options in. Okay, so what about hip function? Okay, does a total hip give patients better hip function? We certainly have a lot of small trials that have shown that. And there was a small but significant improvement in the WOMAC score. The WOMAC is 24 patient questions about function. There are no differences in any other patient-reported outcomes, so not the EuroQual 5D, not an SF-12, and very critically, there was no difference on any objective measure. So anything that a timed up and go or anything a physician can measure, there's no difference. And I do think one thing you can take away from this is a patient has to be able to answer 24 questions about their function to get the benefits of a total hip arthroplasty. If they have confusion or dementia and cannot answer 24 questions, they probably will not have a benefit from a total hip that you can pick up. Okay. So conclusion here, secondary outcome, total hip arthroplasty was associated with a modestly better patient-reported outcome score, but a slightly higher incidence of serious adverse events than a hemi. Okay, so you could take these two studies combined, and on one hand, you could say that, well, they're all average, there's no difference in any of them, it doesn't matter what I do. Or you also could take away that, wow, hemiarthroplasty is awesome, I'm never fixing another femoral neck fracture. And I think both are reasonable conclusions looking at those two studies. JOT, as I mentioned, put out 12 secondary studies, and that's what I'd like to sort of pour through here in the next half an hour or so. And I do think they answer some maybe better questions and some of the questions that other people have asked. So first of all, first study, you'll see these red numbers in the top. That's me going through the 12 studies. First of all, are these really the same population of patients? It's really easy to say the inclusion criteria looked similar. Age greater than 50, femoral neck fracture. The health group did have only displaced fractures, but the faith group had 32% displaced and 68% non-displaced fractures. There were some slight differences as to when patients had operative treatment within 3 days or 7 days, and some slight difference about ambulatory, but they could use a cane or a walker in both trials. So I think we can really look at this and say, wow, those look like the same patient populations. And I told you, these are really, really smart people, okay? So they must be the same. We do know that the faith group excluded 22% of the patients and the health group 36% for dementia. Well, that starts to concern me. And we do see that both groups had not very many institutionalized patients, and I certainly think that does not fit our data here at OHSU. We see a far greater proportion of institutionalized patients. So, and then finally, follow-up, if the surgeon had concerns about follow-up with this patient and then making it to 2 years, they could be excluded. So we sort of get to this question, are these standard femoral neck fracture populations or are they special populations? And we need to do better of inclusion and exclusion criteria. The FAITH trial screened 7,300 patients, but only found 25% eligible. The health trial screened 9,500 and only had 19% eligible. And these are mostly just the surgeon saying, I don't know if I can follow this patient. And I think we've all been there in trials and research we do. It's really easy to exclude patients. And you'll see coming up that this really has some consequences. This paper noted the PROFER trial on proximal humerus fractures. They had 1,250 eligible patients, but the surgeon excluded 80% of the patients for other reasons. And perhaps those have some consequences in the generalizability of trials. In fact, what we see is just alone on age. There's a significant difference between the age of these patients. The FAITH trial, even though they were all age greater than 50, the average was 72. In the health trial, the average was 79-year-olds. So the age is different in these two trials. The ethnicity was different. There were more white patients in the health group. 95% of the patients were white in that, and similarly in the FAITH. And so there's some concerns about generalizability of this to non-Caucasian populations, and several paragraphs in this paper about that. 32% of the patients in the FAITH trial were taking no medication, with substantially more taking medications in the health trial. The comorbidities, the health trial group had many more comorbidities and also had a significantly higher rate of osteoporosis. So I think some of the conclusion of this paper, looking backwards, is that maybe these two trials are not enrolling the same patients despite best efforts to do that. So what if you only look at the displaced femoral neck fractures? Because both trials enrolled displaced femoral neck fractures, right? The health trial enrolled 1,400 of those, and the FAITH trial enrolled 346. Actually, if you look at just this group, the differences between these two studies are even worse. The age went from 78 to 66 different. The ASA classification, the FAITH trial had many, many more class 1, 2 patients, and the health trial had many, many more 3, 4, and 5. And this is sort of a stunning bias for the best we can do in orthopedics. Trials that were published in Lancet and in New England Journal of Medicine. And I think, reading between the lines of this paper, I think Mark Swinkowski was probably a little shocked that this is where we end up, that there's that sort of selection bias. It is really, really difficult to control. Okay, so number 2, well, what about loss to follow-up? Okay, so overall, you could look at this and say, of the 2,500 patients in both of these trials, only 9.8% had loss to follow-up. So that seems really, really great. Boy, I wish all my studies were that good. But they designed the studies that you only needed to have a 2-year follow-up to get to this number. And in fact, in the health trial, only 42% of the patients had complete questionnaires at 1 week, 2 weeks, 6 weeks, 10 weeks, 6 months, 1 year, and 2 years. And so they designed the trial that way to get that. And I do think that's one little learning thing for me is, as I write a paper, you can design the paper to say, we are not expecting all the patients to complete all the questionnaires. We're just going to really focus on the final follow-up, and that can still get you published in the big journals. Wow. We do know that bias is often introduced when you lack 20% long-term follow-up, so they felt this was a pretty good for both of these studies. The risk factors for loss to follow-up should be not a surprise. Patients with other than white ethnicity had higher lost follow-up. Patients in the US and Canada had higher lost follow-up than the trial centers in Europe. Interestingly, also, the patients who had arthroplasty versus some sort of internal fixation also were more likely to be lost to follow-up, and the authors postulated that that was because the arthroplasty group had a lower surgical revision rate than the internal fixation group, so it was probably a little more difficult to get them back to clinic. I'd specifically note that death is not discussed, and to my mind, all the patients who died are lost to follow-up, so I would label 13 to 15% of patients were lost to follow-up because they're dead. Okay, trial number 3, factors associated with death. Okay, we have nearly 2,500 patients, and there was a 4% 90-day mortality and a 13.5% 2-year mortality. The factors above the red line here were associated with 90-day mortality. So every 10-year increase in age has association with mortality. BMI, I have to be very clear, a normal BMI was not associated with excess mortality. It's actually thin patients with a BMI less than 25 that have increased risk of mortality. Patients who are obese, that was found to be protective against death. I don't know if it's protective against surgical difficulty in the operating room, but it is protective against death. Use of an ambulatory aid versus independent was predictive of higher death rates. And of comorbidities, end-stage kidney disease was also noted. Interestingly, ASA classification was not, and comparing internal fixation versus joint replacement was not associated. They did note a 10-year death rate in this population was predicted at greater than 70%. Type of anesthesia was also not predictive of higher mortality. And 2 little things of extra note, mean time of surgery in both of these trials was 57 hours. Remember, this was started back in the early 2000s. So there was some concern about that. We try and do a little bit faster these days, but there was no difference in mortality from time to surgery. And this also follows recently the hip attack trial was present just a year ago. This was a large European trial trying to get patients into the operating room in under 6 hours from diagnosis in the emergency room, which gives me chest pain to think about getting a hip fracture patient to the OR in under 6 hours. Fortunately or unfortunately, they found no difference in that speedy compared to patients within 24 hours. Okay, trial number 4. Well, what if you just say, faith was stupid? Why would you ever fix a displaced fracture? I'm throwing out the 32% of displaced fractures. And so in this group, what if we just treat the patients like we would treat them here? And so this study here, arthroplasty versus internal fixation in the treatment of undisplaced femoral neck fractures. So what this is they took the faith undisplaced fractures, 734, and they compared them to the health arthroplasty patients. And I look at this as, wow, this is a really good use of the data. To me, this study right here of all the 12 is probably the most useful one, so I'll spend a little extra time on it. Okay, well, first of all, yet again, the age is different between the 2 trials, okay? The group that got an arthroplasty was slightly older than the group they got internal fixation. The group that was healthier by ASA classification was more likely to get internal fixation compared to the arthroplasty group, which was not only older, was also sicker. There was no difference in the level of institutionalization or the level of using canes or walking aids between the two groups. What they found comparing these groups was that the internal fixation group had a significantly higher rate of both mortality and reoperation than the group with an arthroplasty. So if you sort of look at this in conclusion, despite the ORAF group having younger, lower ASA scores, and those were all undisplaced fractures, whereas the arthroplasty group was displaced fractures, still the internal fixation group had a higher death and higher reoperation rate than arthroplasty. So this is certainly lending some evidence that arthroplasty is a perhaps better operation than some sort of internal fixation for a patient with a femoral neck fracture. I think that follows some data which I'll get to from some other recent studies. Okay, but what about the very, very sickest patients? Should they still get cannulated screws, right? I don't want to put a really sick person through an arthroplasty. Well, the paper actually chose to look at this. And what they did was they stratified the groups into low risk, low, medium, and high risk quartiles. So the lowest group, you know, is the youngest group. The highest risk group is the oldest. The lowest risk group has lots of ASA 1-2s. The high risk group has lots of ASA 3-4s. And look at some of these other things. So they could have done that by subgroup analysis, which has some problems. They did a super fancy statistical technique that I'm not sure I completely understand, but I looked into it, called heterogeneity treatment effect, and it's supposed to be even more accurate than this. And what they found with this, comparing the lowest risk versus the highest risk group, is certainly up here at the top. The worst quartiles had more mean events. So the last quartile had 30% adverse events, and the first quartile had only about a 5% adverse event. At the healthiest quartile, there was almost equal equipoise between internal fixation and arthroplasty. Not a huge difference. The sickest group had the most benefit from an arthroplasty. Small benefit in the middle quartiles, but that sickest group is the group that could most benefit from the arthroplasty. And in the discussion of this paper, it was really felt that basically the sickest group can tolerate one operation, it needs to go well, and it needs to get done right. The internal fixation group was much more likely to be able to tolerate a slow healing period and much more able to tolerate a failure. Remember, this group may have a 20% failure rate of their surgery. They were more able to tolerate that and get to a revision. So I thought this slide right here might be the most useful slide of the whole 12 pieces in the journal, that arthroplasty is a pretty good operation even for the sickest patient. All right. This fits some of our other recent studies, which I pulled up here. We've seen recently in 2013 that Garden 1 and 2 fractures collapse far more than we expect with cannulated screws. 42% in the Garden 1s and 63% collapse more than a centimeter in the Garden 2s. Yes, Dr. Dong, still no dementia patients in the sub-analysis. They were all excluded. I see that from the chat. We also had a recent trial in 2019 looking at non-displaced Garden 1 and 2 fractures, specifically the risk of being female, having greater than 20 degrees of posterior tilt and age greater than 80 years. That group of patients treated with cannulated screws had a 42% conversion rate to arthroplasty, again lending confidence that perhaps Garden 1 and 2 fractures do not do so well with some sort of internal fixation. And finally, a recent trial published looking at randomized prospective hemiarthroplasty versus screws in patients age greater than 70. Not only was there a difference in the mortality group, but the timed up and go test was better at hemiarthroplasty group, and the reoperation rate again was better in the hemiarthroplasty group. So a lot of data coming down that perhaps a hemi is better than screws, and not only that, but perhaps in the sickest patients that may well be the right option. Okay, moving on to study number 5. When is a total hip arthroplasty better than a hemi? I showed you that there was almost no difference in the health-related quality of life outcomes, the patient-reported outcomes, but that did not specify through surgical approach, cement, age, weight bearing. Do those things matter? And so this study specifically chose to look at that. Okay, just jumping straight to the data on the SF12 score. What we found was that a unipolar hemi had worse SF12 scores than a total hip. Patients with a higher ASA score, not surprisingly, had an SF12 score that was worse. Use of an assist device pre-op, worse SF12 score. The partial weight-bearing group, the group that was allowed to be partial weight-bearing post-op, which turned out in the health trial to be almost 30% of the patients, also had worse SF12 scores post-op. So clearly, of those 4 things, 2 of those are within the surgeon control. One is a hemi versus a total. Very interestingly, bipolar hemi arthroplasty versus total hip arthroplasty had no difference in the SF12 scores. And certainly making the patient full weight bearing post-op is within your control. They did note that the differences were below any clinically detected outcome, but they were statistically significant. The WOMAC scores, once again, unipolar performed worse than a total hip arthroplasty, although a bipolar, there was no difference. Patients with a higher ASA score, use of assist device pre-op, and patients treating for depression had worse WOMAC scores. But again, the difference is likely too small for clinical outcome detection. Okay. So very, very small differences in total versus hemi. I don't know, perhaps there's some data here to suggest that you should be doing a bipolar hemi versus a unipolar, since they couldn't pick any patient-reported outcome differences with a bipolar. Okay, what about cost? Okay, hemi versus total using just the health data, and this is Canadian dollars from a payer perspective. You see down here, kind of just looking at the cost, you know, a total hip, the device is a little more expensive than a hemiarthroplasty, such that the procedure is a little bit more expensive, but otherwise the costs were fairly similar. Physiotherapy, costs from adverse events, a little bit higher in the total hip group, and costs from secondary procedures. And when looking for a payer perspective from the Canadian government, this is sort of some of the data they came out with this math. So in this analysis, under the Canadian system, total hip arthroplasty was not effective to do it for all patients. It was just too expensive for all patients. And a major driver of cost was really length of stay and readmission. And the cost of the implant and some of the complications sort of falls away after that. They did look at a subgroup analysis by age, and they found in patients under the age of 73 that total hip could be cost effective if you were specifically paying attention to the WOMAC and SF12 scores. So once again, don't do a total hip in everyone. Maybe there's a subgroup that might benefit of a total hip over a hemi. Okay, we've all seen this study. This came out in 2017. This is another cost analysis looking at total hip versus ORIF. And what they found was a hemi had worse outcomes and higher cost in all patients. So this is actually the exact opposite finding of the health and trial I just presented. But they found, once again, a total hip could be cost effective in some younger, healthier patients. And so I do think that sort of fits into cost related analysis. Again, total hip, young, healthy patient, maybe it could be cost effective. Trial number 7, what are predictive of adverse events? So 50% of the serious adverse events will happen in the first 90 days. They come through various systems physiologically. You are more likely to have a serious adverse event. Again, I noted this, if you have a BMI under 25 versus a BMI of larger. You are more likely to have an adverse event if you did a total versus a bipolar, but interesting, not total versus a unipolar hemi. No pre-op bucks traction. That group had more adverse events, suggesting you should use bucks traction. again, sicker patients with by ASA scores had more adverse events, more pre-op comorbidity, had more adverse events, and more pre-op thromboprophylaxis had more adverse events, suggesting that maybe between injury and time of surgery, this pre-op thromboprophylaxis, that's from time of injury to time of surgery. So this group suggesting that maybe from time of injury, you should not give the patient any thromboprophylaxis before you get them to surgery. I see the chat. I see all your questions. I promise I'm going to get to this at the end because there's no one single paper that's going to answer your questions. Okay. Looking specifically at things that matter to surgeon. What about surgical approach? Okay, they had more adverse events with the anterolateral and lateral versus a posterior approach. So I won't repeat what we talked about at M&M this past Monday. That would suggest a slightly higher dislocation for a posterior approach, but there were more adverse events medically with the lateral and anterolateral approach. Certainly revision arthroplasty versus primary arthroplasty had a super high risk of adverse events. And this is just following the patients who ended up getting a revision. And that should be no surprise to any of us. There were no adverse event differences with patient age, regional versus general anesthesia, whether or not you use cement, if you pressurize the cement, and blood loss had no differences. Okay. So that might suggest, coming back to that one, sorry, cement is good. Any type of anesthesia is good, and it probably doesn't matter what the patient age is. You should be able to get them through an arthroplasty, and it doesn't matter what type you're doing. Okay, study number 8, looking at what factors increase the risk of revision surgery when you did an arthroplasty. And this is one slide. They were unable to identify any factors that led to revision surgery. Age, BMI, comorbidities, independent ambulator, surgical approach, length of surgery, femoral cement, femoral head size, femoral head offset, and also hemiarthroplasty versus total. If you had an arthroplasty in this health trial, they couldn't identify anything that had a higher risk of revision surgery. Everyone is average. Trial 9. Well, what about, does a total hip lead to less pain? And I find this is a really interesting study. Somebody asked a question that I think this answers right away. So of the 1,441 health patients, at 1 year, 11.4% of them had moderate to severe pain, and at 2 years, 11%. So if you do an arthroplasty, there's an 11% chance the patient's still going to have hip pain at 1 and 2 years. Those are good numbers to remember to talk to patients. All right, but what you really want to know is the total hip group or the hemi group having more pain? This is the question you all ask me. So there was an increased risk of pain at 2 years if you started with hip pain pre-fracture, and that may get at the question of who had arthritis pre-fracture. If you used opioids, if you were female, age less than 80, so younger patients were more likely to have pain, and if you had a higher functional status pre-op. So again, younger, healthier patients are a little more likely after an arthroplasty for femoral neck fracture to complain of pain 2 years down the road. And I think that fits my clinical experience. I believe that as well. There was no change in the risk of pain if the patient had a total hip versus hemi. Both groups still had 11% pain at 1 year and 2 year. Therapy made no difference. Weight-bearing status after surgery made no difference. The surgical approach made no difference, and whether the patient had an adverse event made no difference. So type of surgery and whether or not the patient had pain pre-op, which I do think is a proviso for did the patient have arthritis before surgery, that made no difference in pain at 2 years. To specifically answer the question in the chat, they did not look and examine in the health trial whether the patient had arthritis pre-op prior to surgery and prior to fracture. They did, though, however, look at the risk of pain. So maybe no risk of pain versus either surgery. And somebody asked me, Jason asked me, does fellowship training matter? This is a really cool study. So this is a slightly different group, but Samir Mehta saw this data. He's from UPenn and sort of said, hey, I think I can do something interesting. So they went back and looked at all of the surgeons, and there are many, many surgeons in this group. And you know, of the fractures in the health database, 281 were taken care of trauma fellowship trained, 394 in arthroplasty fellowship trained, other fellowship trained. So in our group here, this would be like sports medicine, hand, tumor. Some unknown fellowship. These were more likely to be European, and a substantial group had no fellowship training. Okay, but do remember, all the patients had a surgeon competency requirement. So does this matter whether you get, what are the outcomes of total hip versus hemi? Super cool study. Okay, so first of all, there was no difference for hemi versus total in either of these fellowship trained groups for death, dislocation, serious adverse event, or reoperation. No difference versus hemi versus total. No difference if there was post-op use of an assist device. So the overall conclusion is type of training is not affected by total hip versus hemi, and all surgeons should be competent and feel comfortable doing arthroplasty surgery. Two small differences, though, that were reported. One is discharge to facility versus discharge home. So if the small group of surgeons who had no fellowship training versus the group of surgeons who had an arthroplasty fellowship, the no fellowship group was more likely to discharge to a facility. I think that fits what we might guess. Care pathways make a difference. The arthroplasty group probably is much more likely to have a really dialed in care pathway and thus is more likely to get more patients to home. I do think that's something all of us can take away from this data is the arthroplasty group has a good care pathway. We should get on that train. Okay, and then one other little small difference. Looking specifically at prosthetic joint infection, hemiarthroplasty had no difference between any of the fellowship groups. But if a total hip arthroplasty was performed and the patient had a prosthetic joint infection, there was a difference between whether the patient was trauma or arthroplasty fellowship trained versus unknown fellowship and arthroplasty versus no fellowship. So this suggests that total hip arthroplasty is maybe a little bit of a special animal. Again, care pathways make a difference and perhaps surgical time makes a difference. And that's what this smaller Mabry paper found when comparing surgeon fellowship training, is that arthroplasty trained surgeons were a little bit faster, and perhaps that does play a role in the development of a prosthetic joint infection. Okay, we're getting there. Paper number 11, VTE in hip fracture patients. What if you dump them all together and look at VTE? So 79% of the patients had pre-op prophylaxis. Again, this is from time of fracture to time of surgery, remembering that the average time to surgery was 57 hours, and 99% of the patients had post-op prophylaxis. Of that, 73% of the patients had only Lovenox, 18% had only mechanical, many of the others had warfarin, a DOAC, or some combination. The overall rates of thromboembolic disease is very small, 1.4% symptomatic DVT, 1% PE. Of those, 55% of the events were in the first 6 weeks, but still 45% were after the first 6 weeks. And I think that's a really hard number to get at. We don't want to anticoagulate these older, frail patients long term. And that's just a good number to know. I don't know how to solve that problem. Total hip versus internal fixation does increase the VTE rate, and hemi versus internal fixation also increases the VTE rate. So arthroplasties had higher VTE rates than internal fixation. There was no difference between age, comorbidities, the type of prophylaxis, so Lovenox versus sub-Q heparin versus warfarin versus DOAC, no difference, and also no difference from time to injury to time of surgery. All right, so that's that one. And study number 12, this is a super cool study looking just at looking at basis cervical femoral neck fractures. So in this, they only looked at the FAITH trial and they wanted to know, is there a difference in the sliding hip screw torque between left-sided and right-sided fractures? So to sort of describe this, remember when we're putting in a sliding hip screw, as you're turning the screw righty-tighty, on right hips, that tends to lock in your reduction at the basis cervical femoral neck, whereas in the left hip, the righty-tighty tends to displace this fracture. And this has been a theoretical concern for all of us for a long time. Does this increase the failure rate? They only had 60 cases that had implant failure. There was no relation to site of fracture. So the answer is no, there's not a right or a wrong side to this. They did have increased failures with female sex, pre-op for use of an assistive device, and displaced femoral neck fractures. But they also found, this compares well to another trial that was published recently looking at intertroch fractures. So I think we can put to sleep right hips are equal to left hips with a sliding hip screw. Okay, so that's all 12 studies. You all asked me a lot of questions, and I subtitled this, How Do You Beat the Average? Because I think that's what we're all interested. Number one, accept that we are average surgeons and that most patients are average. And I think that's how you beat the average, is just drive your patient to the average for most patients. I think looking at all this data, hemiarthroplasty does very well. This is always acceptable. It's better for displaced fractures. It's better compared to internal fixation. It's better in your sickest patients compared to internal fixation. And it does very well compared to total hip arthroplasty for the vast majority of patients. Of note, yes, today we were only talking about ground level falls. So remember, internal fixation may still be an option for, your 50 to 70-year-olds with high energy injuries. That was not addressed at all in my talk today, but I think for the patients that have ground level falls, age greater than 50, hemiarthroplasty does very well. Overall, do less internal fixation. Get really good at the hemiarthroplasty operation you do. That is how you beat the averages. Overall, if you're gonna do a total hip, get trained at it. You've got to select that patient group very, very carefully, and you have to do an excellent surgery. This group of papers does not tell you that use of an assist device or a cane preoperatively is an exclusion from a total hip, but I think it should make you question that. I do think you should accept the fact that your total hip patient is going to have a higher dislocation rate than your hemi patient. Can the patient follow instructions, and can you do the surgery well enough to lower your dislocation rate? I do think in a wide variety of patients, we found that the complication rate of medical events was slightly higher in total hip versus hemi, particularly in the first 90 days. So you've got to do that surgery quickly and in a patient that's healthy enough to tolerate that slight increase in risk. And this really comes down to what I've labeled here, individual shared decision making. These are hard decisions. You just got to go talk to the patient and do the right thing. And I don't have a whole lot of answers other than that. This is sort of my last slide from all of this. As I look through the chat, hopefully I've answered most of those questions. Fellowship training doesn't matter too much. Somebody asked me about arthritis pre-op. That may not really matter. Hemi is a really, really good operation, and that's sort of my conclusion of looking at all that data. Does anyone have any other questions? Dr. Brady asked about total hip, better choice for hemi versus the young. I do think there was some data here, both the cost and some of the patient-reported outcomes. You can take whether the age is under 73, the age is under 65. Age is only a number. I do think in young, more active patients, healthier patients that you think you can beat those complication rates, it is reasonable to consider a total hip. But understand that you're not making them have fewer reoperations in 2 years. You are maybe improving their patient-reported outcomes in 2 years on very small benefits. And those benefits may not last for 10 or 12 years because only 20% of the patients will be alive in 10 years. So you got to pick your young, healthy patients for a total hip very, very carefully. I think there's some really great stuff in the chat. You should look back through it. I have tried to tell all of you carefully as you're learning all sorts of things, whether you're learning femur fracture surgery or ACL surgery or clavicle fracture surgery or ankle arthroplasty versus fusion surgery. There's some things in orthopedics that the outcomes are really clear. Femoral shaft fracture, you should get a nail. You actually don't have to know that literature very closely. Everyone benefits from a nail. It's this stuff with a lot of nuance that you've got to pay attention to. So if you're a knee surgeon who does ACLs, you need to know that literature backwards and forwards if you're going to beat the averages. If you're an ankle surgeon and you want to do arthroplasty versus fusion, if you want to beat the averages, you're going to have to know that literature backwards and forwards. And hopefully today I've presented some stuff about beating the averages for femoral neck fractures. Dr. Anisian asked me about cognitive capacity. Dr. Anisian, all patients with dementia were excluded from all these trials. I have no answer for it other than to say that even in healthy young patients in the health trial, they found very little benefit to a total hip. I cannot imagine in any way patients who are demented would be able to benefit from a total hip. The only benefit of a total hip was on the WOMAC score, a patient who could complete 24 questions about their function. So if you can't answer 24 questions, there is no way with cognitive capacity your total hip is going to beat a Hemi. It's just not out of this data. And maybe the final thing I would say before I close is, again, these are huge, well-designed studies. I'm not sure we can go out and design a better study, nor maybe should we. We might just have to take the nuance in this data and move forward. This is too much expense. I can think of better uses for $15 million than repeating a hip fracture trial. There are a lot of homeless people out there. There are a lot of food instability. This world has other problems than whether a Hemi versus a total is a better operation for a femoral neck fracture, and maybe we need to move on. Okay, thank you so much everyone for listening. Have a great day. I'll close.